All right, let's talk about something you're going to see all the time in the outpatient department: uncomplicated typhoid fever. We're going to build a really practical, step-by-step game plan so you can manage these cases confidently and safely. Let's get right into it. So, picture this. A patient walks in, tells you they've had a fever for 5 days straight, and paracetamol just isn't touching it. This is your classic starting point. That one single clue, a stubborn fever that just won't break, should set off a little alarm in your head. And that's exactly what we're here to do. Walk through the entire process, from that first flicker of suspicion all the way to a solid, effective management plan. So here's our roadmap. We're going to break it down into 5 key parts. First, how to spot the classic signs. Second, and this is super important, how to tell a simple case from a really dangerous one. Third, our game plan for investigations. Fourth, the actual treatment. And finally, how to keep an eye on your patient and know exactly when it's time to call for backup. First things first, it's all about pattern recognition. Long before you even think about ordering a lab test, your clinical brain has to piece together the story. Really understanding the typical way typhoid presents is the foundation for everything that follows. Getting this right from the start is absolutely key. You know, the fever and typhoid is interesting. It rarely just hits you like a truck. Instead, it kind of creeps up on you. We call it a stepladder pattern. For the first few days, the fever just gets a little bit higher each day. Then it hits a plateau, a high, continuous fever that just sits there. After about a week of feeling generally unwell with a headache, that's when the classic stomach issues start to kick in. And this is why that first question we asked is so important. The fact that paracetamol isn't working well isn't just some minor detail, it's a huge clue. So why is that? It's because the fever is being driven by this massive systemic inflammation from the Salmonella endotoxin that's circulating everywhere. A simple paracetamol is like trying to put out a forest fire with a water pistol. It just can't keep up. Okay, let's talk about the gut. The abdominal pain can be pretty vague, kind of all over, but sometimes it settles in the right lower quadrant, making you think it could be appendicitis. Now, here's a clinical pearl for you. In adults, constipation is actually more common than diarrhea. That's because the immune tissue in the gut, these things called Peyer's patches, get all inflamed and swollen, which basically slows the whole system down. And always remember to ask the patient to stick out their tongue. That classic coated tongue with a white or yellow center and bright red edges is a sign you don't want to miss. All right, I need you to really focus here because this is probably the single most important part of this entire protocol. This is where you make the call. Can this patient go home, or do they need to be in a hospital bed right now? It is a huge fork in the road, and making the right choice is everything. Let's look at this side by side. On the left, that's your straightforward, uncomplicated case. Some mild bellyache, they're thinking clearly, vitals are fine. But on the right, those are the alarm bells. We're talking severe, unrelenting pain, which could mean the bowel is about to perforate. Any sign of bleeding, any confusion, sometimes they call it typhoid psychosis, or a drop in blood pressure, well, that's it. This is no longer an outpatient problem. This is a medical emergency. Just to be crystal clear, if you see even one of these signs, the game changes immediately. If their abdomen is rigid or they're guarding, that's a hard stop. You have to assume their intestine is perforated until proven otherwise. If they just look toxic and sick, or if they simply can't keep any fluids down, they cannot be managed at home. Your job instantly switches from treating them to referring them, and you have to do it fast. So, your patient seems stable, no major red flags. Phew! Now it's time to prove our diagnosis. This is where we use lab tests to back up what our clinical senses are telling us, and we need to do it in a smart, logical way. Think of this as putting the puzzle pieces together. Different combinations of symptoms can point you in the right direction. That classic stepladder fever plus the gut symptoms, that just screams salmonella. But you know what? Even just a fever with that coated tongue and constipation should have you thinking about early typhoid. This helps you build a really strong case before you even get a single lab result back. Here's the order of operations for your tests. Always start with a simple CBC. Now for serology, timing is everything. A super common mistake is ordering a Widal test too early. It won't be positive until after day 5 of the fever, because it needs time for the body to make antibodies. Wait for the immune system to catch up. A blood culture is your gold standard, especially early on when the bacteria are in the bloodstream. But let's be real, it isn't always practical or available in an OPD setting. And finally, go ahead and check the liver functions. It's very common to see a mild bump in the liver enzymes. Now here's a classic clue you'll find on that CBC. With most bacterial infections, you expect the white blood cell count to be sky high, right? But with typhoid, it's often normal or sometimes even low. The real trick is to look at the breakdown. You'll see a higher percentage of lymphocytes than you should. It's called relative lymphocytosis, and when you see it in a patient with a long fever, it's a massive clue pointing right at enteric fever. Okay, so you've done the detective work, you've confirmed your diagnosis, and you're confident it's an uncomplicated case. Now for the action plan. Let's talk about a clear, evidence-based treatment protocol you can start using in your clinic tomorrow. These are your go-to weapons. And in a place like India, where antibiotic resistance is a huge problem, your choice really matters. Azithromycin or a third-generation cephalosporin like Cefixime are your best bets. And please, look at that note at the bottom. The days of handing out ciprofloxacin for typhoid are over. Resistance is so widespread that it's pretty much useless as a first-line option now. Look, antibiotics are only half the story. Supportive care is just as crucial. Pushing fluids is non-negotiable. You have to prevent dehydration from that high fever. Tell them to stick to a light, simple diet because their gut is already inflamed and overworked. And of course, rest is essential for the immune system to do its job. Giving a PPI to protect the stomach is also a really good move. Okay, this is a big one. What not to do. Under no circumstances should you give them NSAIDs, like ibuprofen. Why? Two big reasons. First, they can irritate the gut and increase the risk of a serious GI bleed. Second, they can mask a fever or worsening pain, which might be your only clue that a life-threatening complication like a perforation is happening. Same goes for steroids. They suppress the immune system, which is the last thing you want. Just stick to paracetamol, please. We're almost there, but you can't relax just yet. You sent the patient home with their prescription. Job done, right? Nope. Outpatient management is an active process. Your job isn't over when you write the script. You have to follow up, monitor for improvement, and be ready to change the plan if things aren't going right. If you remember one number from this entire talk, make it this one: 72. 72 hours. 3 days. This is your critical window. After you start the right antibiotic, you absolutely must see some signs of improvement within 3 days. If you don't, alarm bells should be ringing. It's time to stop and rethink everything. So when that patient comes back for a review, don't just ask, "So how are you feeling?" Be specific. Ask these 3 key questions. Is the fever actually starting to come down? Is your appetite coming back? Appetite is often the first thing to go and one of the first things to return. And is that stomach ache getting better? The answers to these questions will tell you everything you need to know about whether your treatment is working. And this is your eject button. This is your checklist for when to pull the plug on outpatient care. If they're not better after 72 hours, if they can't keep their pills down, if any of those red flags we talked about pop up, it's time for admission. Same goes for high-risk patients who just aren't turning the corner. Your number one job is to keep your patients safe, and sometimes that means knowing when to hand them off. I want you to let this one sink in for a second. It really says it all. You could pick the perfect antibiotic, but if you're not paying close attention, if you're not actively looking for trouble, you could completely miss a disaster like a bowel perforation until it's too late. Your watchful eye is the best safety net that patient has. And to finish up, let's zoom out. You've gotten the patient better. That's fantastic, but don't stop there. Typhoid is a disease of sanitation. So what's next? Are you thinking about where they got it? About counseling them on safe food and water? About the possibility that they could be a chronic carrier? Managing the individual is step 1. Thinking about the health of the community, well, that's what makes you a truly great clinician.